Okay, I'd like to welcome people to our October 19th meeting of the IMAG MSM Working Group on Multiscale Modeling and Viral Pandemics. Amazingly, this is our third year anniversary, and it seems appropriate that for that anniversary, we revisit modeling of epidemics and pandemics, which is something we've often moved away from a bit over the past 3 years. As always, I need to remind people that this meeting is live streamed and recorded for people to view offline. And so please be aware of that. Our initial meeting was on October 22nd in 2020. We've had 125 meetings so far. There are more than 150 individual talks available online. And of course, there have been many successful papers and grants that have come out of our joint meetings. And I hope later in the season, we'll be able to do a little bit of a recap on that. And of course, this year we started GLIMPRINT.org as an organization to try to consolidate these achievements. As always, Tom Helikar and I are available for comments and suggestions and questions. Jim Sluka and Lorenzo as well. We appreciate your participation and support. We have our usual communication channels, the former Twitter MSM Viral hashtag, the IMAG MSM wiki page, the LinkedIn page, the YouTube feed of all of the seminars, and then the GLIMPRINT web page. It would be wonderful if people would help us populate those with additional content. The GLIMPRINT page in particular could use some love from people helping to develop that as a communication channel. Again, we have that MSM Viral hashtag. Please help us retweet that when needed. There are a couple of announcements we want to make. There is a position at staff scientist in neural developmental dynamics, focusing on multi-scale modeling of development in zebrafish. If people are interested in that, you might want to look into that. There is also a multi-scale modeling position at United Therapeutics Corporation in Silver Springs, Maryland. They're looking at modeling lung epithelial development in organoid culture that might be of interest to people as well. There are a number of RFAs that are open at the moment that might be of interest to people. EU Horizon program has a number. There is the Single Electronic Data Interchange Area RFA, accelerating the implementation of new approach methodologies, maximizing the potential of synthetic data, which is something people like Gary Ann have talked about in previous meetings. Next generation scientific instrumentation tools and methods for advancing digital solutions, which is directly related to our interest in digital twins. Innovative Health Initiative. And then here in the United States, NSF 23616, Ecology and Evolution of Infectious Diseases, has a significant modeling component, and they'd be more here in terms of epidemiology. Smart Health and Biomedical Research, those also have relatively short deadlines coming up that might be of interest to people. And we will have a steering committee meeting tomorrow morning at 11 a.m. Eastern Daylight Time. If you are expecting to go and you do not have an invitation, please reach out to me or to Jim Sluka or to Tom Helikar, and we'll get you the invite for that meeting. Are there any other announcements before we get started today? Upcoming meetings. November 2nd, we have Lisbeth Garris, who's going to be talking about their enormous effort in integrated virtual human twins. We have Pete Vandegraff from Chitara, and then Tongli Zhang from University of Cincinnati. I don't know whether we'll wind up doing the November 30th meeting because of the Thanksgiving, but we'll definitely meet on December 14th. Please send us your ideas for speakers. As always, feel free to suggest yourselves, your students, your postdocs, or anybody that you would like to hear from. Lorenzo is extremely efficient at getting people to come to speak. We want to make sure that we have people that are of broad interest to this community. And now we have Bruce Lee, who's going to be talking about multi-scale modeling from H1N1 influenza pandemic through the COVID-19 pandemic. And I love the retrospective for the future title. Really do appreciate you coming today to speak to us.
Yeah, so thanks, James. I'm going to be talking about multi-scale modeling, sort of a retrospective of some of the modeling that we've done from the 2009 H1N1 flu pandemic through the COVID-19 pandemic, and really kind of look. This is a bit of a look back as well as a look into the future. First of all, I just want to acknowledge a number of different funding sources that supported the work that I'm going to be presenting, ranging from NIH to HRQ to the Gates Foundation. And so basically, I'm going to go through, this is an overview of what I'm going to go through. The fact that many factors and processes really affect infectious disease spread, that there are a need for complex multi-scale policies and interventions, and that the impact of infectious disease is multi-scale and far-reaching, and really go over some of this work that we've done over the past decade and a half. So as all of you probably know, that there are really many factors and processes that really affect infectious disease spread, and these cross many different scales. So there's certainly biological factors, there's certainly social behavioral factors, there are economic, environmental, these all combine to really affect infectious disease spread. And as a result, you really need multi-scale policies and interventions. One of the challenges that we've seen throughout this the COVID-19 pandemic has been a focus on one policy at a time or one intervention at a time. And as many of you have probably seen, there's a need for more of a layered multi-scale approach. And of course, we know the impact of infectious disease is multi-scale and far-reaching. So for these reasons, we started developing in the 2000s models that really represent everything ranging from the biology of people, within people, to people and their actions and their behaviors, to their movement within different locations and interactions with each other, to the physical built environment, to all these different things that will affect the spread of infectious diseases. And as all of you know, computational modeling can really help address these complex systems. So this is a quick overview in terms of the timeline of our pandemic, epidemic related work over the past 15 years or so. And I'll go through some examples of each of these things. So they range from the H1N1 flu pandemic in 2009, when our team was embedded in Health and Human Services to help with the national response. And we worked with DHS, CDC, and other governmental organizations. And then really around the same time and moving into the decade of vaccines, that's when we started what described as our Hermes work, where we're modeling vaccine supply chains and vaccine distribution around the world. And for this, we're talking about not just vaccine distribution for epidemics and pandemics, but also routine immunization distribution. When the Zika outbreaks occurred, we developed models of spread of Zika to help inform some questions that members of Congress had. And then we've also looked at things like malaria. And then before pandemic, before the COVID-19 pandemic, we're continuing to model different types of pandemic prevention and control strategies. And of course, as you know, we starting 2020, our world was suddenly faced with the COVID-19 pandemic, and we continue to build different types of models to help with decision making. And for instance, some of those models were further adapted for an interactive tool at by the New York Times. We've also worked with different decision makers across all levels, ranging from local to state to national to international decision makers. So this is just a quick retrospective of some of those things. So let's start with the 2009 H1N1 pandemic. So as I mentioned, we were embedded in Health and Human Services, helping with decision making. And if you recall, back in 2009, the fall of 2009, the vaccines weren't immediately available. In fact, they came out with a schedule in which some of the vaccines were available at the beginning, and each week there was different sets of vaccines that were available. So there was a delay in vaccine availability. And one of the questions that we were asked is, okay, if you've got the flu vaccines, the H1N1 vaccines, who should receive these vaccines first? So we developed an agent-based model of the DC metropolitan area. And this basically included each person in the DC metropolitan area was represented by a computational agent. That computational agent had all variety of different types of demographics, ranging from sex to age to socioeconomic status. And each of these agents were assigned different households. So we had geospatially explicit representations of all the households in the DC metro area. We also represent all the schools and many of the major workplaces as well. And during the course of the day, we would have these agents would move amongst the different locations, whether they're schools, depending on the agent's age, workplaces, and the community, and they would interact with each other. And these agents basically mirror the population of the DC metropolitan area at the time. And what we did was we then seeded the flu pandemic or epidemic in this area and watched it spread. And then we looked at a variety of different vaccination approaches. And the results of this was published in Health Affairs. And we found that actually, if you vaccinate low-income neighborhoods first, when you have a limited number of vaccines, it's actually beneficial compared to just randomly distributing them or vaccinating people in higher income neighborhoods. And the reason for that is that many of the lower income neighborhoods have much higher population density, and you have more movement of people from low income neighborhoods to high income neighborhoods for work. So if you think about it, there are many people who move from low income neighborhoods to work in different businesses and different organizations that are in higher income neighborhoods, but you have much less the reverse. You have much less movement from higher income neighborhoods back to lower income neighborhoods. So because of the population density and then the greater, broader mixing, it is actually beneficial to cover the lower income neighborhoods first. And this is an example of a utilitarian benefit of an approach that also has altruistic benefits as well. And it's also one of these findings which may not be obvious if you don't explicitly represent the population in a very detailed way. In the spring of 2009, we're also asked to look at different scenarios, such as different social distancing scenarios, such as school closures. Many people don't realize that school closures were on the table in the spring of 2009 in terms of considerations of possible interventions. So basically, we looked at how the effect of school closures, if maintained throughout the pandemic, could actually delay the epidemic peak for up to a week. But we found that if you prematurely open schools while the pandemic is still going on, you actually may feel the pandemic and get an increased bump in cases, because what happens is these closed schools and then people aren't mixing, and then later on in the pandemic you're suddenly releasing all these susceptibles back into the population. It can be adding logs to the fire, and you're actually feeling the pandemic, and you can actually get more cases. So we concluded that you really need, if you're going to do this, you need to maintain it throughout the entire pandemic, and we costed this out, which would be prohibitively expensive. If you were to shut down schools throughout the entire pandemic, that would just be too expensive to society, and therefore it was not worth it. And this was part of the evidence that suggests that at this point it's really not worth closing schools back in 2009. And of course, there's also social impact and all those different things. So that's an example of some of that school closure work. We also looked at the impact of vaccinating different percentages of different company workforces, and not surprisingly, this showed a lot of benefit. If you want to make sure so we these runs to see what happens if you cover different percentages of the workforce. And also what you can see here is the impact of vaccinating like ACIP priority groups, vaccinating critical infrastructure workers, essential workers, et cetera. So this, of course, it's not surprising that there's benefits in protecting essential workers and critical infrastructure workers, but what this showed is really, it helped quantify the benefit of that. And when you quantify the benefit of that, you can actually help then determine how much needs to be invested into prioritizing these individuals. So those are just some examples of some of the work that we did throughout the H1N1 pandemic. And as you can see, some of those questions were actually questions that later became relevant for the COVID-19 pandemic. And one of the challenges that we did see is there were learnings from the H1N1 pandemic that weren't necessarily translated or carried over to the COVID-19 pandemic. So we did see, there was a buildup of more and more scientific insight and knowledge dating way back to the mid 2000s, and then leading right up to 2020. And some of these learnings may not have been immediately translated. So I can move on and cover quickly some of our other work between the flu pandemic and the COVID-19 pandemic. So for instance, we looked at, we did some modeling of the Ebola outbreaks that occurred in West Africa. This was in the mid 20-teens. And for instance, this quantified the cost of an Ebola case. So we basically created computational models that would show, okay, what happens if someone actually gets infected, and then that person can then develop different types of clinical sequelae. And then we microcosted each of these clinical sequelae in terms of the direct medical costs, as well as the decreases in productivity. And of course, many people who get sick with Ebola have very severe symptoms, so the decrease in productivity is significant. And we know that you can have up to a 50% mortality rate. So when someone dies prematurely, then that's a huge hit when it comes to societal productivity. So this basically quantified those things. And then we also used modeling to help decision-making with the Zika outbreak. And here's just one example of that. We quantified the potential impact of Zika to help inform budget allocations that were occurring. So if you recall back when the Zika outbreak was occurring, very early on, decisions had to be made in terms of how much to allocate, what kind of budget should be allocated towards the Zika response. So there was a proposal by the White House, and the Congress was debating over whether to increase, decrease, or maintain the same amount that the White House was proposing. And we ran our models to help determine the potential impact of the Zika outbreak if it went unchecked or if it went controlled to varying degrees, to give Congress a sense of how much that cost would be. Because naturally, if you're going to invest a certain amount of money and the potential cost would be much higher than that investment, then it's worthwhile to have that investment. So this essentially showed, this was published in PLOS Nuclear Tropical Diseases, this essentially showed what happens in terms of productivity losses, Medicaid costs, direct medical costs, and total costs when you have different levels of different attack rates with the Zika outbreak. So we developed a model that represent the southern portion of the United States, which were the states that were most vulnerable to the Zika outbreak, and then represented the spread of Zika in those locations, and then what would ultimately happen. And ultimately, we found that the resulting costs, in many cases, significantly exceeded the budget numbers that were being discussed in Congress at the time. And then we also, following the Zika outbreak, there was interest in developing different types of Zika vaccines. So we used our model to test the impact of different types of Zika vaccines, and using different assumptions like, what are some of the different target groups that should be targeted? What should the cost of the vaccine be? And, how does the value of the vaccine vary with different levels of coverage? 25% versus 50% versus 75%. And this essentially shows a graph of the different targeted populations, as well as the, each of these different lines represent different vaccine cost scenarios and coverage scenarios. And this really shows at what point do things become cost effective and in fact cost savings. And there are many situations in which the vaccine is cost savings, which provided fairly strong evidence that it's worthwhile to continue with development of different Zika vaccines, and ultimately the Zika vaccines would provide value if they reach the market. So another area of work that we did in the meantime was also working on vaccine supply chains. Now, not many people realize that there was a lot of supply chain work that occurred throughout the decade, and that actually proved to be quite helpful come the COVID-19 pandemic. So around 2007, 2008, we basically, and this is the map of different efforts. So back in 2009, we formed what we called the Hermes Logistics Team. And basically, it was a team of modelers as well as operations research experts that would then go to different countries and develop models of the vaccine supply chains in each of those locations. So these were discrete event simulation models that represent in detail all the steps involved in vaccine distribution, ranging from the vaccines being produced at different manufacturers to being shipped to a given country, to arriving at the central store and then maybe being stored there, and then being distributed to all the subnational and regional and district and town locations, going through different types of transport vehicles. So we represent each of the different transport vehicles and the storage containers and those things like that. And we also, in some cases, merged these vaccine supply chain models with disease models. So like, for instance, measles models. So if we're representing the distribution of measles vaccines, we could see how this distribution would ultimately affect the control of measles in some of the countries that were part of the measles belt in Africa. So this just basically goes through some of these different countries. Like we developed models of supply chains in Niger, Thailand, Vietnam, Senegal, India, Benin, and if we move on to the next page, we've got Mozambique, Zambia, and we use these models to identify where some of the bottlenecks in vaccine distribution. We looked at the impact of changing different vaccine characteristics. We also tested the impact of using drones to distribute vaccines. Now, it's interesting because, again, this occurred 2009, 2010, and then, over time, there's more and more movement to really redesign a lot of these vaccine supply chains and improve them. And so there was work on these vaccine supply chains leading all the way up to 2020, which in many cases could have facilitated a lot of the vaccine distribution that occurred after that. So, one has to wonder if this work didn't occur, how much worse off would things be had we hit the 2020 pandemic and there were still a lot more bottlenecks in vaccine distribution. And so, this led me to write this article that was published in Stat, urging everyone to not repeat the mistakes of past vaccine distribution efforts. And as you can see, this was published in mid-December, which was right around the time the COVID-19 vaccines became available in the United States. And one of the warnings that we had was that you really have to think about vaccine distribution strategies before it actually occurs. There was a lot of focus around the time on getting that vaccine to market. So get the vaccine to market and also purchasing the vaccine. Unfortunately, there was not nearly enough focus on how are you going to actually distribute the vaccine in a way that's going to reach people. So if you recall, there was a lot of snafus in December 2020 and early 2021, where there were delays in the vaccines getting out there. There were queues and in some cases a bit of confusion. So again, this is a situation where there were a lot of learnings over the previous decade about vaccine distribution and the importance of that. And unfortunately, some of these learnings did not translate into policy around the time. So you might be hearing this on repeat. It's really important to carry these learnings forward. So we learned these things during the 2009 pandemic, in between the pandemics and during the COVID-19 pandemic. How can we get these insights that are learned through modeling studies, through modeling work, to be more perpetual, to be passed along, so that when we reach another epidemic or another pandemic, which we all know is going to happen at some point, how are these learnings then going to be accumulated and consolidated and actually used going forward? So that brings us to the COVID-19 pandemic. And I'm going to just give a few examples of some of the work that we've done. Again, in a lot of cases, this is a very quick overview, it's scratching the surface. But our work did receive a fair amount of coverage in the media. These are just some examples of how our modeling work was covered. And so one of the things that we did early on in the pandemic, and this was in the spring of 2020, is we developed a model of the United States, and we simulated the spread of COVID-19, or actually I should technically say SARS-CoV-2 throughout the US, and then try to get a sense of what the economic impact of the pandemic would be. And we felt that this was valuable in the spring of 2020, because you have to make investment decisions, like how much needs to be invested in terms of preventing the spread of the pandemic. And as you recall, back in spring of 2020, there wasn't complete clarity on how severe this pandemic would be. Those within the know knew that, okay, this is problematic. We're seeing these mortality rates, these hospitalization rates, and these things like that. But many people in different sectors across the United States were just not clear. Like, well, how severe is this? What's the problem going to be here? Will there be an economic impact of the different mitigation strategies? So we felt that was important to show, well, here's the economic impact of the pandemic if it goes unchecked, or if it goes checked to varying degrees. And this was published in Health Affairs, where we essentially showed, the cost was significant. So here it basically is just the graph showing the percentage of the US population that gets infected with SARS-CoV-2. And then you can see on the y-axis the resulting direct medical costs. And we also looked at productivity losses and those things like that. And as you can see, they can quickly get quite significant. So you can balance that off and say, okay, this is what would happen if you actually didn't implement control measures. It didn't necessarily say which control measures would be the right ones, but it shows that this is what you need to worry about if you don't really actually invest and implement in control. Also during 2020, if you recall, especially in the spring and the summer of 2020, there were a number of vaccine candidates that were being developed. And at the time, the US Food and Drug Administration came out with a statement saying we really want the vaccines to have at least 50% efficacy. Now that raised the question, well, okay, where's that number coming from? And really, what should we be aiming for in terms of vaccine efficacy? So we basically took our models and ran different types of vaccines at different efficacy levels to give people a sense of, okay, what kind of value will be provided at different efficacy levels. And we found that, so basically here we have vaccines have to have an efficacy of at least 70% with 75% coverage to basically prevent or quell the pandemic or epidemic. So we ran different scenarios. As you can see, these are different R naughts because, early on, the R naught was, estimated to be around between 2 to 3, but of course, as we know, things have changed with that. And then x-axis, we show vaccine efficacy, and then we look at the reduction of cases and total cases averted, and all these different things. And we found that there's a significant inflection point when you get above an efficacy of 70% and you get above 75% coverage. That's when you can really quell the epidemic/pandemic. Now we have to keep in mind at this moment, we were looking at a wide variety of vaccines, but the results for these vaccines were for vaccines that were transmission blocking vaccines that prevented infection. As we know, after the mRNA vaccines came out, there's a lot of information that emerged afterwards that show maybe the vaccines weren't as effective as really preventing infection. They were mainly more oriented towards decreasing outcomes. So we did adjust our models accordingly to look at that. But just to give you a historical perspective, this was back in the summer of 2020, when the hope was to come up with vaccines that had significant efficacy against infection. And then here we basically, so this was to prevent epidemic and pandemic. So we looked at what happened if you roll out the vaccines to a place where you really didn't have that many cases yet. So that might apply to places like New Zealand, Australia, where they really had been able to prevent cases from occurring, versus a situation where there's already a epidemic and pandemic. So we found that if it's already occurring, you actually had to have a higher efficacy of 80%, naturally, because the virus is already a lot more widespread. Okay, and we developed other models throughout the COVID-19 pandemic, and some of these models were adapted by the New York Times into this interactive tool. So you could go on to their website and look at different scenarios. Like, for instance, this is one tool which looked at, when could the United States reach herd immunity? And basically you could go there and change the different types of scenarios, and then just get a sense of what it would take to reach herd immunity. And this was earlier on in the pandemic, when there was a hope that, once you get vaccinated or once you get infected, you'll have a reasonably long-lasting immunity against against subsequent infection. Now, of course, one of the wrenches that was thrown in there is we've had some, significant number of different variants since, but that's just an example of our work being adapted. We also, early on in the pandemic, looked at the possibility of different types of medications that people could take to decrease the infectious period duration. So, at the start of the pandemic, people were looking at all different possibilities. There's social distancing, so we ran simulations looking at that. Other types of non-pharmaceutical interventions. There's certainly vaccines, and then there's certainly looking at the possibility of different types of medications. Medications can help decrease outcomes, improve survival, those types of things. But medication also potentially, if depending on how the medication works, if it can somehow reduce the infectious periods or reduce shedding, that can also help decrease transmission as well. So this was published in PLOS Computational Biology, and this shows some of the impact, this graphic, in terms of, if you're cutting down the contagious period or an infectious period by certain lengths of time, this is how it translates to cases averted, hospitalizations averted, and then cost savings. So we have to remember that, there's multimodalities that can potentially help prevent transmission, and it's not just vaccines. And then this basically shows what happens if if you're decreasing the average duration of the SARS-CoV-2 infectious period, if you're going from 9 down to 6, and what happens to the case averted. Naturally, the shorter the infectious period, the more the cases averted. And then this shows, each of these lines represent different situations where you're treating different percentages of symptomatic and all cases. And then this shows what happens in terms of, hospitalizations averted and ICU admissions averted. So when you're explicitly representing each of the different types of outcomes, you're explicitly representing different types of healthcare settings, then you can determine what the impact will be on the healthcare system in different ways. We also modeled the impact of different types of face mask use, like N95 respirators. We looked at, if you recall, back in 2020, so many things happened in 2020, and one of the things that occurred was there's a shortage of PPE, personal protective equipment. So we looked at we wanted to get a sense of how many masks, how many N95 respirators were actually needed by hospitals throughout the country, and we developed models to help determine that. And this basically shows that, for instance, a single acute care hospital may require 400 to more than 100,000 N95 respirators per month for COVID-19. This again was back in 2020. And of course, it depends on the size of the healthcare facilities. So we created models of many different healthcare facilities and simulated the use of masks from a day-to-day perspective, and then the spread of the virus and cases. And then we tried to determine here, like we varied the assumptions, because as you recall, in some cases, people were encouraged to wear N95 respirators more often than the manufacturer specified. So we wanted to see what happens if you were able to use it 5 times, 10 times, 15 times, 20 times. And we also looked at the trade-off between timing of vaccination and efficacy. And so what we ran these simulations in 2021, early 2021, when you basically had vaccines moving onto the market, but they were not readily available, or like people were wondering, oh, should I get the Moderna vaccine or the Pfizer vaccine or the J&J vaccine, or these different types of possibilities. And and especially if the vaccines may have varied in terms of efficacy. So we did simulation runs to see, okay, what happens if different people get different vaccines of different efficacies at different times. And we find that essentially that you really it's very important to get protected as soon as possible. It's actually better to be protected by a lower efficacy vaccine than waiting for a higher efficacy vaccine to come around. Because there's a big difference between having some type of protection versus no protection. And essentially this shows what happens in terms of, we found that, maybe you can wait a week or 2 weeks, but don't wait more than a month before, getting a vaccine if you can already get vaccinated today, essentially. This is an op-ed that I wrote for New York Times covering some of these results and some of these findings and insights. So we also looked at the impact of increasing vaccination coverage by different amounts and trying to quantify that. That was published in the Journal of Infectious Diseases. And I know that in the interest of time, we want to try to preserve enough time for discussion. So I'm moving through these slides fairly quickly. This shows that for even a 1% increase in vaccination coverage could avert millions of cases and thousands of deaths. And then similarly, this shows what happens in terms of total direct medical costs and total productivity losses. To give you some historical perspective, that was around the time where there was an initial bump where a lot of people got vaccinated, and then they found the vaccination rates were tailing off. They were getting lower and lower because there's the people who were initially interested in getting vaccinated, like kind of the early adopters and then the secondary adopters. But then people were finding that the vaccination rates were getting much, much lower. So the big question was how much was it worth investing to give a push to increase vaccination coverage? So this provided numbers showing that, look, if you increase the vaccine coverage by just 1%, you're going to have a significant return. So this is the amount that can actually be invested to increase the vaccination coverage. And then this is an example of a study just showing the benefits of maintaining face mask use after certain vaccination coverage levels were reached. Now, one of the things that this really tried to emphasize is that no single intervention is going to be the magic bean, so to speak. In fact, what you really want to do is layer these different interventions really work together. Vaccination can be much more effective when there's face mask use, and face mask use can be more effective when there's vaccination coverage. And then the same thing with these different types of policies and interventions. And we felt that this was something that was very lost during the COVID-19 pandemic. And it's something that modeling can really show, these combined interventions. And this was something that we already knew back in 2009. We ran simulations at the time looking at the combination and the layering of different types of interventions. Yet that talk really sort of disappeared. And this shows what happens when, this is the data when final vaccination coverage is achieved. And this shows what happens when you continue to maintain face mask use for a little bit of time beyond that. Because if you can imagine, if you achieve a certain vaccination coverage, there is a lag time in which, you still have to deal with the pandemic, as we know, and what's the use of maintaining face mask coverage beyond that? So this is an infographic that was developed by the Lancet Infectious Diseases to really look at the impact of that. And just as a final, and again, I'm mindful of the time. We also, I'm the chief technical officer for something called the New York City Pandemic Response Institute, and this was formed back in 2021, funded by the New York City government to form a pandemic response institute that would help generate more evidence and insight to prevent, not just deal with the current pandemic, but prevent future pandemic and prevent and control future public health emergencies. So with that, that's just going back to the overview of what I talked about. And just here's a summary that basically epidemics and pandemics are systems issues, and basically, multi-scale modeling. All these models, which I indicated previously, are multi-scale. They really look at the biology, behavior, people's movements, people's interactions, the environment, all these different types of things can be very valuable, really, basically understanding what should be multi-scale policies and interventions. So with that, this is just a credit to our team, which developed and implemented a lot of these different studies to help with the slide deck, our PHICOR team members, and I guess we can move to the questions and discussion section.
Thank you very much for an inspirational talk. The amount you've done over the past 20 years is stunning. I'll open the floor up to questions. And Lucas, please go ahead.
Yeah, hi. Thanks for the fantastic talk. Found it very interesting. I had one question about the vaccination campaigns that you also studied in some of your papers. And I was wondering, because I read a lot about comparisons, and we also did our own study on the comparison between prime boost first, or prime first as many as you can, and then later on boosting, basically comparing different types of vaccination campaigns. And I was wondering if you also looked at that, and if you were able to draw some conclusions from available data, maybe in the US, comparing different vaccination protocols, and if you could, or if you identified any advantages or disadvantages associated with some of them.
Yeah, so there are some of the key principles with vaccination coverage, especially when you're in a situation where it's not a single vaccination, but it's a series or boost, et cetera. So one principle is it's better to have more of the population with partial coverage or partial protection than a lower percentage with better protection, right? So in other words, just for argument's sake, if you have a vaccine that's like 80–90% efficacious, and that's covering 30% of the population, it's better to cover 75% of the population with say like 40 or 30% efficacy, because there's a tendency to forget that vaccines are population interventions, they're population measures, right? So they protect the individual, but they also protect they're either prevent transmission if you have a sterilizing vaccine or something like that. But even in a situation where you have a vaccine that's decreasing outcomes, you are having some impact in terms of decreasing the shedding and decreasing the infectious period. So one of the things that we've seen in the news and in general public is sort of this distinct binary saying, oh, does it prevent infection? Yes or no? And there's some arguments that, these COVID-19 vaccines do nothing about infection, but they just focus on outcomes. But it's actually more complex. So when you're actually preventing outcomes, you're potentially decreasing shedding, you're potentially decreasing what behavior and changing behaviors and those things like that. So one of the principles is try to get as broad coverage as possible, even if you're not getting great protection. So when you're focusing on, boosting and those things like that, you really have to, and, throughout this pandemic, a booster for one group, in some cases, was primary series for others, right? So try to get as many people covered as possible. And I think one of the challenges that we found also in this pandemic is that wasn't tracked very well. Maybe at the very beginning, but then you start losing, like, okay, well, what kind of coverage is occurring? And there were really no geographic maps over reflecting coverage. So you had the CDC COVID data tracker, which maybe gave you sort of the gross numbers, but we didn't get a sense of what the vaccination coverage was geographically. And that's another thing that's really important as well. And how that relates to the spread. So Lucas, I don't know if I addressed your question, but those are some things to look at.
Yeah. Thanks a lot. I was also asking because there were, I remember that at some point we had discussions with different public health experts, and some states or some regions, for example, in Canada, they implemented protocols where you had a 6-month delay because they wanted to vaccinate as many people as possible, given limited vaccination resources. But other regions, also, for example, in Europe, they implemented completely different vaccination protocols. And I found it interesting from a public health perspective because, as you said, I think there are clear arguments that suggest that one should vaccinate as many people as possible in the beginning and not focus on specific groups and vaccinate them with multiple shots. Yeah. So yeah, thanks.
John, go ahead.
Away from the background noise here. Bruce, I mean, I was kind of in the middle of this thing. I'm not a modeler. I'm not a biologist. And I went through, riding with you guys, learning as I went. I was frustrated as hell with the modeling. It sucked. Are there any models that you know of that were any good, that provided actual actionable, information in a timely manner that got used, and not, it's like how many $1 billion were spent making models back in the early days when nobody even knew what the heck they were talking about? How much time and energy was directed to doing things because some model out of Washington University said 10 billion people are going to die or something on day one? What's the downside of what was done with the modeling? And have we gone back and identified any models that actually turned out to be useful? Do we even know which ones might have been useful? So it's a general question, but maybe some specific examples would help me.
Yeah, so we should bring some historical context into this. So during the 2009 H1N1 pandemic, a lot of the modeling activities and efforts were very organized. So we had the MIDAS network. I've been part of the MIDAS, investigator of the MIDAS network since 2007. And as soon as in April of 2009, when it was clearly something was going on in Mexico and then the spread of the virus, that's when the federal government contacted the MIDAS network and said, okay, let's work together to help with the national response. And so it was fairly organized. So, and at the time, you had people at the White House that managed the pandemic response. You had BARDA, you had the ASPR, you had all these folks, and there was an organized way where we were actually working with everyone very closely. And there were many specific examples. And I actually, we wrote an article after this, and we did a hot wash after this of like how it actually helped pandemic decision making. And so, like, for instance, it helped with determine how best to distribute the vaccines. It helped determine, looking at whether school closures should be done. There was a new antiviral that came out in September, I believe, or October of 2009, and we ran simulations to determine the value of that and who should get that. We also ran simulations to help with ventilator distribution. So there are a lot of examples of that, and there's we actually wrote this up in a couple articles that were summarize what went right and what went wrong. And the MIDAS network met after that and said, okay, these are the things that we felt we did right and these things that we can improve. The frustrating thing about the COVID-19 pandemic is all of that was lost. In 2017, a lot of the people who are veterans in the White House and all these left the government. And therefore, these were people with a lot of institutional knowledge and also knew how best to use modeling. So when we hit 2020, things were a bit chaotic. There are a lot of modeling groups throughout the US and throughout the world that did not know who to interact with. Like, who are we supposed to be interacting with to offer our insights? And in some cases, they were selected, like, oh, we'll get the insight from here and insight from here. And we ran into an issue where, modeling ultimately, science ultimately needs to be separated from politics and political agendas, et cetera. And so we need an objective space where we can run the models and generate the results. And that really just did not occur in 2020. And I think you saw as a result, things were a bit chaotic, and you saw some of the wrong models being used for the wrong situations. And, there were good models out there, but when you use good models for wrong situations, you will come up with the wrong insights. That being said, I think there were still important insights that came from the modeling. The trouble is, it's not always clear how many people, like how many decision makers were actually listening to this. So this is something I think that will be helpful for us as the community to really discuss going forward. I really think a lot of the science generated by models was valuable and important during the COVID-19 pandemic. The big problem was translation. And how do we prevent that from happening in the future? And as a result, I think modeling to some degree got a black eye because it wasn't very portrayed well. The other thing I should add is that you start seeing, on like social media, people like throwing together models, like people who had never done modeling before, and they'll say, oh, I found this result. And you're like, well, where's the actual model? So I think there's a big difference between those who are steeped in modeling, have been doing for years and are well published, and what they've done is validated by the scientific community, versus someone deciding at their kitchen table to suddenly throw together a model and say, this is what I found. So we need to really kind of work on that as well.
Well, that's, it was just amazing to me. Like, one of the first realizations I had that this pandemic was serious was when they disbanded the federal White House Office of Science and Technology Virus Prevention Working Group that had been in place since the 2009 kind of stuff you were talking about, where a relatively small number of academic modelers had been working together for years, and I generally agree with you. They had a systemic way of approaching the problem. And what did we do? We shut that down. I'm not sure why. I'm not sure. But as soon as we did, 100,000 other academics that know nothing about it whatsoever seemed to be generating models. And we had a press that just sucked that stuff right up. And I think couple of the better presentations that this group we're in now had very early on, we brought in some people from the media to tell us, what is it you need to know? How can we help you, the media, really deliver the news that there is a model? No argument. That's news. Here's the model. It has results. What you're missing is the results mean absolutely nothing, because nobody who worked on the model could tell anybody else what assumptions they were making, because they didn't keep track of the assumptions they made. When they ran into needing an assumption to make the model work, they made an assumption. Nobody in the group remembers what the hell they assumed even. But the model now looked to work. And then we had this post-model validation. This is not prediction model. This is post-diction model. After it's all over, I'll tell you if the model was close. And then we get all done with these validated models of predictions of numbers. And a few people held up their numbers and say, boy, we got this tuned up really good. It was right on. And then they find out that the real numbers were all wrong. So they did a great job of predicting the wrong numbers. This is ludicrous. And we got to fix this big time before we get to do it again. I'm sorry. The old guy just once in a while loses it here.
Well, but I think Bruce made a good point, which is you didn't know how effective the vaccines were going to be. You didn't know how much transmissibility or
No,
strain variation there would be. You didn't know how long resistance would last after infection or
no,
immunization. And so I think it's a little unfair to expect that the models are going to be perfect for a new disease where you don't have that information. It would be very interesting to understand how you assimilated as you went forward, how you refined the models to reflect the additional information that came in. So that would be one of my questions. The other one is I hear the frustration, and Bruce, you're very polite, of course, in policy. I guess you have to be polite. John doesn't have to be polite. Philip Ball was polite when he spoke about the frustration of the policymakers not using the available science well. And of course, about the general population not acting in a rational way in response to the information that was available. And those are things that are tricky. We're not so used to hearing cost-benefit analysis in this panel, and I think it's very valuable to get that perspective here. And so I mean, John, of course, is a big believer in modeling. I think his frustration that he's expressing is more about how the lessons maybe weren't taken up as seriously as they could have been. And the question going forward about how do you, I want to come back to this question about validation, because you have very complex models and it's not so easy to validate those. And I'd like to hear a little bit more about that. And then also going forward, what the lessons are, as you say, for the next pandemic.
Yep. And just want to add something, just in response, and thanks, John, for your questions and insight, and similarly, James. The one of the issues too is I think there was a fundamental misunderstanding of how models can be best used. So models are not going to be, models are not going to be effective as exact crystal balls. You can't predict the future. No one can predict the future. Models are most useful in showing key relationships and showing that, helping people understand, all right, when things change, this is how things will change. This is how will alter like what you need to do. And so the COVID-19 pandemic is a perfect example. It's a moving target in terms of the R naught and the characteristics of the virus. So model can help show, okay, if it changes this way, this is how it's actually going to change. We also have to keep in mind, data is not exact. You figure out an R naught from a population in a certain location, that's not the R naught everywhere, right? That's not the RE everywhere. So you can't hang your hat on a very specific number and say, this is the exact number of people that are going to die. This is the exact number of cases. You're destined for failure if you try to do that. No one can predict the real estate market. No one can predict the stock market. No one can predict exactly what will happen with a pandemic. So I think that's one of the challenges. I remember early on in the 2009 pandemic, many of us who were modeling, we were contacted by the press. And I remember a reporter from a very prominent publication contacted me and said, how many people are going to die during this 2009 pandemic? And I said, that's not the purpose of models. The purpose of models are still relationship, blah, 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 et cetera. He said, oh, got it. He said, off the record, how many people are going to die from the pandemic? And I repeated that thing. And I said, you can't tell. We model different scenarios. We don't know which scenario is going to happen. And then he said, got it. Worst case scenario, how many people are going to die? And I was thinking in my head, okay, worst case scenario, everyone dies on Earth, right? I'm not going to be that person who says that and be quoted in a major publication to say that. So we all had this agreement among us and the Midas investigator. None of us will give a number to the press, right? We won't give a death number because we know what would happen. Okay, but what happened is someone outside the network gave a number plastered everywhere. That number was by definition wrong, right? So we as a modeling community have to help people understand what the purpose of modeling is. We shouldn't mislead people and say, this is going to be a crystal ball, this is exactly what's going to happen, because we're going to set ourselves up for failure. It may feel great because you do that, then everyone's listening to you, but then you're going to be wrong. So I think that's one of the key things to do. And then I don't know how much time we have, but you mentioned validation. So when you build one of these agent-based models that represent all these different things, you have to do validation at multiple levels, right? So you have to try to validate how the agents are actually going to move, for instance. So, we put in rules for the agents, like we say, for instance, if an agent is school-aged agent, then that agent will search around and to go to the different school, the closest school, and we divide by districts. If an agent is an adult working, then we have a gravity model that determines where they actually go work, because we're not going to determine where every single person works. And then so we validate the agent movement by comparing where did the agents actually move with, what are the records in terms of, employment and those things, or what are the commuting distances. So we have to validate like the agent movement. We also have to validate things like, the spread of the virus. So we'll compare that with historical data to see if we can recreate that. So for instance, with the COVID-19 models, we had a base model already that was represented flu. So we could validate those against the flu stuff. Of course, COVID was completely new, but we couldn't do retrospective validation, criterion validation at the time. So when it comes to criterion validation, we had to stick with either concurrent or prospective, right? So we do it and see if we actually could predict something over the next 2 or 3 weeks. And then we also did a fair amount of convergence and divergence validation, right? So we would create simpler models in each of those cases to see if it actually corresponded, like if the agent-based model corresponded to, say, like a compartment model, or if it corresponded to, in some cases, a simpler equation-based model. Did they correspond where they're supposed to correspond? Did they diverge where they're supposed to diverge? So for instance, if we're representing differences in the school age versus the adult population in the agent-based model and not doing that in a compartment or a equation-based model, we should come up with different results. If we're coming at the same results, we're like, well, something's going wrong here. So we did do different levels in terms of that.
Well, somebody has to have done it right. I mean, somebody just has to have lucked in to doing the model, I'll say right, and publishing it correctly and handling it correctly in the way they released it. I mean, when we talk to the journalists, it's like, the academics have this new model and it was fascinating. The answer was fascinating. It has nothing to do with right, but man, can we make a headline out of this? But it's the modeler's fault for letting that happen and get into the press where exactly what they're going to do with it. Can somebody fund the search for the 10 examples of any 10 models in the COVID battle where they were done in a way that we would say are the exemplary? I so agree with this idea of lessons to be remembered. Here's all the things that were wrong. But I haven't heard anybody come up with a list of ones that were right.
Yeah,
Now, what we want to remember next time is what are the few, that 2%, that 1% of the models that turned out to have been useful, timely. Okay, I'm done.
I would
It's
actually
late.
suggest it's a lot higher than 1 or 2%. I think there's a large percentage of models that were helpful and effective. The trouble is, we can call it sort of the noisy wrong bunch. So they're just because a modeler or a model is making a lot of noise, that can attract a lot of attention, and it can overlook the people who are quietly doing really good work. I think there's a lot of very good, well-meaning, talented modelers around the world that were quietly doing their work, and they just didn't get attention because they weren't jumping on social media and they weren't like kind of bragging about their results. And many times those are the best modelers. So I would suspect if you actually listed all the models that were very helpful, it actually would be a very long list. But it's the people that drew attention to themselves that might have kind of set things in the wrong direction, I think. So
at the time they did it, it's slow. It takes a long time. And the pandemic does not go on hold while you wait to figure that out. But now that it's over, going some way to systemically go out and find those people you're talking about whose models didn't get in the news because they weren't done yet. And they didn't have the confidence they needed. But post hoc now, okay, looking at some of those models, they're too late to help with COVID, but they may be the key to not, or to doing it better next time. But they're lost. They didn't get in the news because the modeler wasn't ready to tell anybody those results.
But John, I think you're mixing some things that I think Bruce was very careful to separate. One of which is the model itself and its predictivity given the limited information that you have. Another one of which is how the model is communicated with the public and with decision makers. And the third one is how the decision makers and the public act in response to the model. The modeler per se doesn't have control over those latter two things completely. And so I think you know, the model itself could be perfect, but the communication could be poor. The model could be perfect and the communication could be perfect, but decision makers for what, or public for one reason or another might not accept the recommendations of the model. And so there are a whole cascade of things. And so I don't know retrospectively, you could certainly say perhaps what doesn't work. Maybe Bruce could give us some ideas about more effective strategies for communicating. How to work with, I mean, maybe we probably need you to come back and talk about how do you work with the government. Todd Knudsen, who's from the EPA and is involved in regulation, has been on the call and has stuck out. So he's somebody who's involved in this from a toxicology point of view, which of course has a longer term than it does, and has its own set of regulatory and uncertainties in it. I think
I would love to see Bruce have some funding to lead the effort to do some of that. That would be, but who wants to fund that? That's over.
Well, I hope that there be opportunity. I mean, I don't think that maybe Bruce is feeling that way. Okay, thank you, Bruce. We'll let you finish up. I want to thank you for being willing to talk to us. I think you've raised a lot of really great points. I'd love to hear more about the technical issues of model validation. Something that I'm very interested in is you predict a forecasting code of uncertainty of outcomes, but you only have one experimental measurement. How do you do validation in the presence of single time series for stochastic time series for real world data when you have uncertainties in prediction? Forecasting, I should say, because as you point out, prediction is impossible. There's so many issues you've raised today. I really do appreciate you being willing to come to talk to us. And it was really wonderful for our anniversary to have somebody who has done so much and covered so many aspects of modeling and public policy. So I want to thank you again and appreciate people joining us today.